Hello, I am Dr. Santosh Kumar, Orthopaedic and Joint Replacement Surgeon based in Kolkata, the city of joy, and I head the Poorva International Orthopaedic Foundation. Also, I am the founding director of Momentum Orthocare, and I am consultant orthopedic surgeon, orthopedic and joint replacement surgeon at the prestigious Belle Clinic in Kolkata. So before this, we had been discussing. We have discussions on several topics, and today we will be discussing about knee arthritis. Well, as you know, knee is the biggest joint in the body, along with hip, which is another big joint. And knee arthritis is pretty disabling. Most of the knee arthritis that we see is primary osteoarthritis. What it means is age-related wear and tear. And sometimes we see genetic secondary arthritis. In some cases, it is genetic, like juvenile rheumatoid arthritis. It can be ankylosing spondylitis. So juvenile rheumatoid arthritis is arthritis in young age, but mostly the arthritis that we see is osteoarthritis, and this osteoarthritis can be of two types. The commonest one is age-related wear and tear, the way our car tires wear out. So that is known as primary osteoarthritis of knee. Sometimes osteoarthritis can be accelerated because of a secondary factor, and this secondary factor can be trauma, an accident, and fracture, a ligament injury, or rheumatoid arthritis per se itself can accelerate osteoarthritis of knee, and then it becomes secondary osteoarthritis of knee. So whatever may be the cause of arthritis, the end result, the result of arthritis is wear and tear, destruction of the knee joint. The destruction of the knee joint is primarily, it is wear and tear of the cartilage. Like this is our knee joint, and the cartilage wears out. The cartilage wears out sequentially. First it is early stage, then it is moderate stage, and then it is in advanced stage when the cartilage wears out completely. So this cartilage wears out. This is the cartilage. The cartilage, what is this cartilage? Cartilage is the cushion which caps the two end of the two bones to form a joint, and this cartilage wears out the way our car tires wear out. So this is arthritis. So this wearing out of the cartilage causes pain, swelling, stiffness. Stiffness is wherein bending and movement of the knee is difficult. That is known as stiffness. It causes deformity. Deformity means bending of knees. The knee, which is supposed to be straight like this, it starts bending like this, which is known as varus deformity, and sometimes it starts bending like this, which is called the valgus deformity. The problems that we face with knee arthritis is pain, stiffness, deformity, but the biggest problem, of course, is instability. Instability means there is decreasing balance while walking. There is a waddling gait. The person starts walking like this, and with this waddling gait, there is degenerative changes in the spine also, which is known as spondylitis. There is wear and tear of the lumbar spine also, and this wear and tear of the lumbar spine leads to radiculopathy, means there is sensation of pain in thighs and legs also. So the problems with knee osteoarthritis is pain, which is fluctuant in nature. The pain is not same always, but sometimes it increases, decreases, increases, decreases. But with time, the intensity of pain overall increases. To start with, it is pain only on stair climbing and walking. Then gradually, as the pain persists for longer and longer time, it starts becoming continuous dull aching pain, throbbing pain, continuous pain, and sometimes it becomes neuropathic pain. Means when the person is sleeping at night also there will be pain, there will be burning sensation. So all these are neuropathic pains. So to start with, the pain is throbbing in nature, and then it starts becoming neuropathic pain also. So the pain is a factor. Along with that, there is stiffness. What means there is difficulty in straightening and bending of knees. Sitting cross-legged, there will be difficulty in that. There will be deformity. Bending of knees causes instability. Now the problem with this features of arthritis is that it is progressive. Means whatever symptoms are there today, it will increase in another 1 year, another 6 months to 1 year. So the instability, disbalance, there is instability or disbalance, that is progressive. Whatever instability or disbalance is there today, it will increase after 1 year. So the instability or disbalance is the bigger problem than the pain. Because of this disbalance, there is pain in back also, and people have increased risk of fall. All those people who would have fallen and have had some fractures like fractured neck femur or humerus fracture, all of them have fallen because of this bent knees. This bent knees lead to waddling gait, instability, and it increases the risk of fall. So that is the problem with knee arthritis, and if it affects the younger people, it is even more problematic. So the sad part of knee arthritis is that there is not much medicines that we can use now. There is not much medicines to heal this. There are no medicines in fact to heal this. We of course use certain dietary supplements like collagen peptide, glucosamines. We use certain medicines to modulate the pain like neuromodulators, but most of the times there are no medicines for this osteoarthritis. And once it starts affecting your activities of daily living, what it means is that it starts affecting your social life or your personal life or your professional life, or it starts affecting your activities of daily living, then we have to think in terms of surgery. Well, this surgery, some surgeries are there, but the most effective and the most predictable surgery is of course knee replacement, which is basically knee resurfacing. What it means is that we remove this worn out surface, we replace this surface, whatever you were seeing, we replace this surface, worn out surface, with a new surface. So this is what is knee resurfacing, this is what is knee resurfacing or knee replacement. So this worn out surface, worn out surface is replaced with a new surface. So this is what is knee replacement, and this is the implant that is used in knee replacement. And knee replacement is basically it is resurfacing and realignment. Realignment means the knees which have been bent like this are again realigned like this. Knees which have been bent like this are realigned like this. So knee resurfacing, knee replacement is basically resurfacing and realignment. Now these are the knee implants. So knee implants, they have multiple sizes, like your shirt or your pants, they have multiple sizes. So similarly these come in multiple sizes. We measure the sizes and we decide the size based on that. And these implants are put with something called bone cement. These implants are put here with something called bone cement, and these are all cemented implants. What it means is that they are put with something called bone cement, and the bone cement undergoes a polymerization reaction, and then within 10 minutes it is at its maximum strength right in 10 minutes. The bone cement sets within 10 minutes and it gets its maximum strength within 10 minutes, and that's why the person starts walking from the very next day. We are able to mobilize the person, we will be able to make the person walk from the very next day of surgery. That is because it's a cemented implant. It gains its maximum strength right on the table itself, right in the operation theatre itself. So we make the person walk from the very next day of surgery. If we do one knee also, we make the person walk from the very next day of surgery. If we do both knees also, we make the person walk from the very next day of surgery. So either we do one knee or both knees together, we make the person walk from the very next day of surgery. And as far as this knee replacement is concerned, now when we are discussing about implants, a lot of people ask, you give us the best implant, we want the best results. So well, of course everybody wants the best implant, and we always give the best implant so as to where we get the better results. But it's not that one implant is better than another, the A implant is better than B or B implant is better than C. The results are not dependent on the brand of the implant, they are dependent on the precision of surgery. Because knee replacement, and for that matter any joint replacement, is a precision based surgery. It is a surgery in which precision is most important, the surgical technique is most important, the expertise of the surgeon is most important, hence the surgeon is most important. Because see, these implants are put, and this implant, the weight bearing surface of this implant has to be put at 90 degree to the weight bearing axis of the body, with some amount of posterior sloping. These have to be balanced so that the forces inside the implant, the stress inside the implant are evenly distributed throughout the range of movement of the implant. Then this sizing has to be appropriate. What it means is it's the millimeters, degrees, balancing, placement. Is a precision that matters, and this precision is enhanced with robotic arm. So presently we are using robotic arm in almost all surgeries, and this robotic arm gives us an enhanced precision, better bony preparation, better bone dissection, and better results, accelerated recovery with this robotic arm. So robotic arm is the preferred method as for surgery as far as knee replacement is concerned. Well, along with this, this is one of the models of the knee which is known as fixed bearing knee. So we also use rotating platform knees. Rotating platform knees means unlike here, so basically there are This is a bearing surface. On one side is highly polished cobalt chromium, or it can be titanium niobium, which is known as gold knee, and other side is ultra high molecular polyethylene. Now this polyethylene is modular, like this come in multiple sizes, this come in multiple sizes, and this comes in multiple sizes and thicknesses to get the optimal balance inside the knee. So this is modular, and this is example of a fixed bearing knee. And along with that, whenever we find a three-dimensional deformity or a torsion, then we use a rotating platform knee. This is the rotating platform knee. What this moves like this, and this can rotate like this also. So this knee is designed for sitting cross-legged with rotating platform. This is LCS knee. This is LCS knee, rotating platform high flexion knee. Means the LCS means the full form of LCS is low contact stress knee. So as you can see, this surface is highly congruous with this surface. So this congruity leads to low contact stress by maximizing the area of contact throughout the range of movement. So the stresses which is forced by area is minimized, and this is known as low contact stress knee. And this, along with flexion extension, this can rotate also for sitting cross-legged. So this is the beauty of this knee. This can be used as for sitting. This knee can enable a person to sit cross-legged also, and if a person is able to sit on ground also, I don't think there should be any problem while using this knee. So it can enable a person to sit cross-legged. It may enable a person to sit on ground also. Along with this, the activities which are allowed after knee replacement include unrestricted walking, stair climbing, driving, swimming, trekking, but one should avoid impact activities like jumping, skipping. Impact activities should be avoided, squatting should be avoided, and commodes should be used. The day after, we always try to keep the whole experience as painless as possible. We try to make the whole experience as painless as possible, and we use multiple modalities for pain control. The first itself is the robotic arm surgery. Robotic arm surgery leads to less pain because of the enhanced precision and less cutting, better preparation of bone, smoother surgery. So this is the robotic knee replacement itself is less painless. It is less painful rather, and it is by and large painless. And then along with that, to control the pain, to manage the pain, we use nerve block. We use ultrasound guided nerve blocks to control the pain, and along with that, we use multiple transdermal patches like fentanyl or buprenorphine patches to control the pain. So we try to keep the experience as painless as possible. So by and large, it is a painless knee replacement, and we mobilize the patient from the very next day of surgery. If we do one knee at a time, then we keep the patient for 4 days, 3 to 4 days. If we do both knees at a time, we normally keep the patient for 5 to 6 days. By the time of discharge, patient is able to go to washroom, sit on chair, commode, and patient should be able to climb stairs. Patient is generally able to climb stairs. So once the patient goes back home, the person is independent, expected to be independent. The person is able to go to washroom on his or her own, use the commode, climb few steps stairs, and of course we should be using a walker for first 15 to 20 days or a month or so, walker or a stick. So now we get a lot of queries whether one knee should be done at a time or both knees can be done together. Well, there are 3 ways of doing about it. I prefer both knees in single sitting many times when the knees are bent. Like we can do both knees in single sitting, that is known as bilateral simultaneous knee replacement. We can do one knee, and after a gap of 4-5 days or 2-3 days or 5-6 days, we can do another knee, that is known as bilateral staged knee replacement. And we can do one knee and then send the patient back home, and then after a few months or within a year, we can do the other knee, that is known as unilateral knee replacement. I strongly believe that doing in single sitting, that is bilateral simultaneous knee replacement, is better than giving a gap of 2-3 days or 4-5 days, because once you give a gap of 2-3 days, then it becomes 2 surgeries. Medically it becomes 2 surgeries in a very short span of time. So you are giving anesthesia twice, the patient is undergoing surgery twice, we are giving IV fluids twice, so we are challenging the heart and the kidneys twice. But once we do in single sitting, although both knees are done, but medically it is one surgery. We are giving anesthesia only once, we are giving IV fluids only once. So medically it is one surgery. For us to do one knee replacement, it takes around 20 to 30 minutes, and both knee replacements simultaneously can be done within 50 minutes to 60 minutes. That is less than an hour. And we normally mobilize the patient from the very next day. We get a very common question, when should we do the knee replacement? When should we do the knee replacement? Of course, the answer is whenever knee arthritis in form of pain or instability restricts your movement, restricts your social life, restricts your professional life, and creates a hindrance in your activities of daily living, then we must consider knee replacement. As far as the radiological features are concerned, that is, we see in X-ray, we see bone on bone arthritis, means the bone starts touching with other. There is, once the cartilage disappears, we can see this bone is touching with this bone. So that is, we see in X-ray, that is bone on bone arthritis. Now for us to see in an arthritis in any imaging, we need a standing X-ray. What it means is that there should be standing weight bearing X-ray. The person should be standing. If the person is lying down, then the arthritis will not be appropriately assessed. The deformity will not be properly assessed. So we have to keep in mind, whenever we have to do X-ray for arthritis, it has to be a standing X-ray, not a lying down, not a sitting X-ray. MRI per se has not, MRI has almost no role as far as knee arthritis is concerned, assessment of knee arthritis is concerned. MRI is good for ligament injuries, cartilage injuries, sports injuries, but as far as arthritis of knee is concerned, MRI has not much role, because MRI is always lying down. It cannot make a person stand and do MRI. So any imaging for us to assess arthritis has to be a standing imaging. It has to be a weight bearing imaging. The body weight has to fall on the knees. Then only we can understand the amount of deformity, amount of bending, or the amount of arthritis. So we have to do proper imaging for us to understand. These are the radiological criteria or the X-ray criteria of arthritis. There are, as I told you, functional criteria. Functional criteria means when knee arthritis starts affecting your professional life, social life, you have to think twice before getting out from home, or it starts affecting your activities of daily living, daily routine. When it starts affecting your daily routine, then you have to consider knee replacement. So this is the functional criteria. We have X-ray criteria, that is radiological criteria, and then we have objective criteria. Objective criteria means we see when the knees have started bending, the straight knees, if they have started bending like this, then we have to, then it is a, then that stage needs knee replacement. Whenever there are objective criteria like bending of knees, there, which is known as deformity, it needs knee replacement. Whenever there is stiffness, means the knees are not getting fully folded, it is getting stuck in between. Whenever there is severe stiffness, whenever the range of movement is drastically decreased, the range of movement of knees is decreased, that means the person needs knee replacement. So these are all objective criteria of knee replacement. Once a person has decided to undergo knee replacement, then the person should immediately start muscle strengthening exercises, because muscle strengthening is very, very important as far as the results of surgery is concerned. So muscle strengthening exercises should be started before surgery itself. You should have to start quadriceps drill, which is known as quadriceps drill, muscle strengthening exercises. They have to be started before surgery itself. Quadriceps drill has to be started before surgery itself. They are mostly static quadriceps exercises, or rather say isometric quadriceps exercises. If you start the exercises before surgery, the recovery will be faster. And exercises have to be done after surgery also. Mostly they are isometric exercises. They are all quadriceps and hamstring strengthening exercises. We have to focus on muscle strengthening after knee replacement and before knee replacement. We have to start muscle strengthening before surgery itself. Now this muscle strengthening is of paramount importance. I have seen majority of the people focusing on knee bending, folding knees. Well, folding of knees occurs to a certain extent automatically once the swelling and stiffness, once the swelling and decreases. But muscle strengthening is of paramount importance, and it has to be done. Several times there is hamstring muscle is tight, so we have to do hamstring stretch. Because of this tightness of hamstring muscle, hamstring stretch has to be done, quadriceps strengthening has to be done. And after surgery, we have to use a lot of ice compress for the inflammation to be controlled. Like to control the inflammation, we have to reduce the swelling, and once the swelling decreases, the knee starts folding and range of movement comes back significantly. before surgery itself, we do certain pre-operative investigations like blood test, ECG, echocardiography, and we assess the heart and the kidney function. We assess the levels of hemoglobin. If somebody's hemoglobin is low, we may start iron tablets before surgery itself. And of course, all these things are continued after surgery also. We continue the medications after surgery also for some time. So all these things are there. And what to expect after knee replacement? Well, after knee replacement, you will start walking from the very next day of surgery. By the time when you come back home, you will be walking on your own. You will be carrying out activities of daily living like going to washroom, sitting on commode, climbing few steps stairs, and bathing is normally done after stitch removal, but it can be done. Presently we have waterproof or swim proof bandages with which you can do bathing also after surgery, immediately after surgery. And first few days we need to you may need to sit on higher chairs, higher commodes, and after few days or few weeks, you will be able to sit on low chair, low commodes and sofas and all everything. And the people who go to office, they can expect that they will join office by 1 to 1.5 months, and by 3 to 4 months one can go outside. And go outside means one can start going to mountains also. One can start doing trekking also. Four-wheeler driving starts by a month or 1.5 months. Cycling starts by 1.5 months, and one can start outdoor walking by 2 to 3 weeks. After stitch removal, you can start walking outside, and the more you walk, the better it is. The more active you are after knee replacement, the better it will be for you, the faster will be the recovery. Many people ask me, what is the correct age of knee replacement? Well, as far as the age of knee replacement is concerned, knee replacement has to be done whenever it is needed. What it means is, if a person needs knee replacement at 25 years of age, it has to be done. If a person needs knee replacement at 75 years of age, also it has to be done. Because the purpose of knee replacement is to provide painless and stable movement in the active and productive years of life. So the person who gets the most benefited from knee replacement are the people who are active and in the productive years of life. So whenever it is needed, it has to be done. And most importantly, the normal lifespan of knee replacement is 25 to 30 years, and after that, if it is needed, it can be redone again. So one need not bother about that. That is known as revision knee replacement. That is equally successful as primary knee replacement. And so whenever a person needs a surgery, it should be done. Of course, before surgery we need to assess fully, and then we go ahead with surgery. And rehabilitation in terms of muscle strengthening is very important after surgery. And presently, to provide higher precision, to provide accelerated recovery, we are using robotic knee replacement surgery. Robotic knee replacement surgery is the future, and we pioneer in the use of robotics in robotic knee replacement surgery. And presently, most of our surgeries are robotic knee replacement. We welcome you all, wherever you are. If you or your anybody known to you, your family, friends, anybody needs knee replacement, you can very well come to Kolkata and contact us. We will facilitate you in all ways, and we assure you to provide the best and the safest and the most predictable results at the most economical prices right here in Kolkata. And if you have any query, please feel free to write to us at my email ID santdr@gmail.com, or you can WhatsApp me at 9831911584, or you can WhatsApp me at 62899622271. Okay, I am just repeating my phone number once more: 62899622271. Thank you.